the guy who lives across the road from me. And I know him, and I know his 2 kids, and how are things? How are the kids? I asked him. And he's like, Tori, can you believe it? They told me, I went to the dentist, and this dentist had the nerve to tell me that Ruby needs to have braces. Are you kidding? She's 7. What a racket, those orthodontists. And I just kind of sat there. So who's your dentist? And he told me, and I said, did they talk to you about it at all? And he goes, no. He goes, but I know that when I was a kid, I had braces when I was 12. And now these orthodontists, they get in there when you're 7. It's all about making money. It's such a racket. And I said, oh. He said, did they give you some names of orthodontists? He goes, yeah. He goes, he gave me this name of a woman, Victoria something. And I'm like, Victoria Linsky? And he's like, Tori, I didn't even put it together. And he's like, oh, I'm so sorry. And I said, no. I hear this, maybe not to that extent, almost every day. From new patients, dads that call up, moms that come in for exams, that say the same thing. You know, my goodness, my child is only 7. She's so little. Why are we being sent in to see the orthodontist? And I think that's really important for everybody to understand, because I can sit there and say, well, there are these, you know, things that the advantages of doing early treatment, but it has to come from the whole team together. So, you know, whenever we're in dentistry, we've got our dentists and our support staff, our RDAs and our hygienists, even our receptionists and our treatment coordinators. All of these people, it all works together as a village. If we all understand why a certain treatment is being prescribed, it makes it a lot easier for the patient to understand it, and they're not so resistant when they walk in the door. I almost always, when I have a patient who's very young coming into the office, the parent will sit there. I only want to do 1 phase. I've looked up this 2-phase treatment. I only want to do 1 phase because it's going to cost me so much more money. It's going to be twice as expensive to get orthodontist. And it's not really true. So I'm going to go through this today. I'm going to go over our objectives today is to define early treatment. What does that mean? We're going to talk about who is and who is not a good candidate, some common problems that get addressed in early treatment. We're also going to go over some options available and when you should refer the patient. Sorry. I'm not technologically advanced. So there are a couple of different definitions. So we have phase therapy. This is what a lot of people hear about. Phase 1, phase 2. I even heard about this magical phase 3, which I'm not quite sure what that is. I guess maybe, I don't know. Phase therapy is early dental problems that left alone will create an unhealthy environment for the growth and development of the teeth, gums, bone, and jaws. It can be preventative, so it can prevent a problem from happening. There's also interceptive orthodontics. This is where you're intercepting a developing problem. So you're seeing something that's going to happen, and you get involved early so that it doesn't become a big problem. And then there's growth modification. This usually brings up the biggest questions when we do phase treatment. It's timing treatment to maximize the growth of the bones of the jaw. Okay? So for treatment phases, this is how I deal with early treatment in my office. So we have a first phase, which is about 12 to 15 months of active movement. Okay? So it's going to take about 12 months or so for the teeth to be moved into the right position. When I have my kids at about 12 months and they're looking pretty good and we want to take the braces off, I sit down and talk to the parents. How responsible is your child? Are they going to do okay with the retainer? Are you worried they're going to lose the retainer, leave the retainer, break the retainer, throw the retainer away, let the dog eat the retainer, microwave the retainer, or what? And inevitably they say, I don't want to have to pay X amount of dollars for a new retainer. What can we do? And I say, well, let's leave the braces on for 3 months. We leave them stable. We take impressions for retainers. We get them back 3 months and take the braces off. They only have to go into retainers at nighttime. Okay, so that's why there's kind of this big span, 12 to 15 months. If someone has horrible oral hygiene, then of course I'll take them off for 12 months. But it's something that I'm going to want to see more regularly to make sure that they're wearing their retainers, that those teeth are being held into position. After that 12 to 15 months, there's a maintenance phase. When they go into retainers, the retainers are made in such a way that we can adjust them around growing teeth, so they don't have to have multiple retainers during their maintenance phase. As those permanent teeth grow in, time also monitoring whether or not they're going to need to have a second set of braces. And then we have phase 2, which would be your second set of braces. It's when all the permanent teeth are in, usually up until the 12-year molars are starting to erupt. And it's about 12 to 15, maybe 18 months. And this is kind of lining up the teeth that have come in a little bit crooked, those permanent teeth that come in, or even the second molars, which are can sometimes be a challenge. So now that we know what the treatment phases are and how we define early treatment, the big question is when and who should we refer for early treatment? So what is normal in a 7-year-old? So when we see a typical 7-year-old, that's when the American Association of Orthodontists recommends you refer a patient to see an orthodontist to make sure everything's okay. Now 7 is kind of, it's a good number, but it may not be the right number for your patient. I think 7 is the latest, but if you start seeing developing issues, you want to send them over a little bit earlier. There's the class, you want to make sure that the first molars are in. Class 1 is normal, where they have good balance on their molar teeth and also skeletally. We have this little ugly duckling stage. Don't really want to say that in front of the patient, but it's when these teeth are coming in and they kind of look a little splayed out. And they're splayed out because we have developing canines that are pushing on the roots of the laterals. They might have some spacing. The most important thing is that during this transitional period where we've got new teeth growing in, perfect tooth alignment is not really to be expected, and it shouldn't be a cause for alarm. Here's a great, we had a patient come in, looked pretty normal. We see these pictures, little ugly duckling stage going on, lots of spacing here. Got some high canines developing, which are pushing the roots of these teeth out of the way. We've got the permanent dentition. Oh, there's not one there, and there's not one there. So this was a great patient to send over because we can talk to them about what we can do about those missing permanent second molars, second premolars. So what's not normal? And you guys can stop me if you need to stop me. Or if I'm going too fast, just let me just slow down. So what's not normal? Well, a class 2 dental, class 3 dental skeletal, they usually show up this way. So we have an overbite, so a distance between the top and the bottom teeth, or an underbite, like this, which is a class 3. Whenever we see somebody with these relationships, it's very important that you want to get them seen by the orthodontist. So a class 2 skeletal relationship can show up vastly different. You have 2 totally different looking patients that are both class 2. Somebody with a long face and deep bite, or you have somebody with a real short face and deep bite. So 32% of the malocclusions out there are class 2s, but they're what we see about 70 to 75% of the time we see class 2 malocclusions. The upper jaw is set, or is forward relative to the lower jaw. In the skeletal class 2, both of the jaws can be malaligned, or it can be just one. There's excessive overjet, so the upper teeth are way out in front of the lower teeth. That could be because the lower jaw is set back, and it could be because the upper jaw is set too far forward. But either way, we've got these teeth that are way out here, and the lips and everything want to strain against them. They're at a much higher risk for trauma when we have those protruded incisors. If it's untreated, skeletal malocclusions like this, class 2s, may require orthodontic surgery when they're older. And that surgery can be either to take care of the overdeveloped maxilla or the underdeveloped mandible. Okay. So I have a couple of x-rays up here. So if we take a look at this patient, we've got these really protruded top teeth. You can see this face is really long. They've got an open, what we call mandibular plane angle. The jaw is really long. He's going to grow this way. And then we've got this guy who's got a little short face here, but he's also class 2. And they're treated 2 different ways. So on the top one, we ended up having to go with an extraction pattern and full fixed appliances. The other option, if they're going to be really, really good, and if we have good growth factors, then we might go with a high pull headgear. How many people do you think want to wear a headgear the appropriate amount of time when they have sports and tutoring and school? It's really, really tough. And the bottom one shows a growth plan. So this is a patient that has really good growth factors that they're going to grow forward. We can use functional appliances. Now, back in the day, functional appliances were these big contraptions that went in people's mouths, and the kids could take them out. And they were really, really good if they got used. And a lot of the studies on functional appliances were done overseas, like in Germany, where kids did what they were told. I can say that because my PRC is German, so don't kill the messenger. But nowadays, a lot of the functional appliances we have are inside the mouth. So we can do them, we can use a Herbst appliance or a Forceps appliance, and there's 1,000,001 different types of appliances that can get these results. But what they essentially do is they stimulate growth of the lower jaw. Essentially, they posture the jaw forward, so it allows the condyle, which is back here, to have some pressure on it, which causes some growth. Now, if a patient isn't going to grow, they don't have good growth factors, it doesn't matter how much force you put on that lower jaw, it's just not going to grow. We're good, but we're not as good as the man upstairs. So for a class 3 skeletal relationship, it's typically characterized, we can see it very early on when the maxilla is deficient, whether it be in the transverse direction or if it's set back a little bit. We can see that very early in mid-face deficient patients where the upper part of the face is really flat. The typical class 3 that you think about with the large lower jaw, we tend to see that more so when they're older. And the class 3 patients are very challenging because they continue to grow until they're 18, 19, 20 years old. So we might try to fix things when they're younger, but we always have to monitor them until the end of their growth spurt, which can be in the late teens, early 20s. Only approximately 3% of the malocclusions are true skeletal class 3. Again, they can be caused by lack of growth in the upper jaw or excessive growth in the lower jaw. For early treatment, what we're trying to do is correct both the sagittal relationship, so the underbite, as well as the transverse, so expanding their upper jaw as well. And I hope everybody's been eating very well, because now we're going to look at bones. So when we talk about a class 3 patient, this is kind of the one that you can look at and you're like, oh, I know that when they go into the orthodontist, they're not going to hear good news. When we have a jaw that's really deficient in the sagittal direction, meaning the upper jaw is set back relative to the lower jaw, what we need to do in that situation is loosen up the sutures of the upper jaw and move this jaw forward. Okay? One of the best ways to loosen up the sutures is to do an expander. Okay? So a lot of you have seen expanders on patients. We take these expanders and we modify them so they can also have a headgear attached. So as we expand and the sutures start to get loose, we also protract that maxilla, bring the maxilla forward. Okay? These little guys that you send over, this is tough for them. So we usually bling out their headgear with, glitter and metal shards or what have you, whatever the boys like to hear, stickers, things like that. But this is one of the hardest things to correct. But doing it when they're young, about between 7 and 9 years old, we get fantastic results of being able to bring this upper jaw forward. So if it's truly that the upper jaw is kind of stuck in behind the lower jaw, doing this early is a great, great way of getting the jaws lined up so that they can then grow together. Another thing that is not normal is a functional shift. So if we take a look at this patient, their midlines are off, but the midline is off because when they're biting fully together in centric occlusion, with all their teeth together in the back, it's hit this tooth already, and it shifted the lower jaw off to the side, okay, in this direction. We take care of that, canine, do a little expansion on the upper, that midline lines up perfectly where it's supposed to be. So when we see a midline asymmetry, we look for missing teeth and we look for crossbites. There are also issues like habits and medical problems that can also affect whether or not a patient needs early treatment. So finger, thumb, or tongue thrust, speech discrepancies. We have patients that are mouth breathers that can really affect the way that the jaws are going to continue to grow. They tend to grow more vertically rather than front to back. Okay. TMJ dysfunction, rheumatoid arthritis, and growth hormone abnormalities are very, very rare, but these can also lead to orthodontic problems. So vertical relationships, right? We see this situation over here where the teeth are, where we've got an open bite, the teeth are not overlapping. Well, they may not be overlapping because they're still growing in, right? You've got little teeth in there. They may not be overlapping because there's a crossbite. They may not be overlapping for lots of reasons. So when we see a situation like this, those are some things. If it looks like the crossbite's all corrected, everything looks good in the back, it just looks like the teeth need to erupt a little bit more, that's okay. However, when we see a situation like this, we've got a big crossbite, this is about 5 millimeter open bite. This is huge. This is scary to see. Same with this one over here, crossbite in the back. We definitely want to fix that. Okay? We might even fix it with something you're not used to seeing. So instead of just having rings around those back teeth, we might have acrylic on the expander. And I'll show you a picture of that in a minute. Other vertical relationships are deep bites. So when we have a deep bite and the upper teeth are overlapping the bottom ones, we have a much higher risk for wear to the hard tissue, so getting wear on those incisors. We also have gingival issues where the bottom teeth actually hit the back side of the top teeth and that papilla back there and get really inflamed gum tissue. You see these kids, they've got really red tissue and kind of, why are you not brushing properly? And they could be brushing really, really well, but they're hammering that gingiva with their bite. This can be caused by a skeletal issue, or it can be caused by just over-eruption of the front teeth. So when we see a patient like this, where we've got this really gummy smile, or we have an excessive curve of spay, that too can contribute to a deep bite. And then we have crossbites. So anterior crossbites. They can be skeletal, which would often happen in a class 3 patient, or they can just be dental, where we've got a tooth that came in a little bit behind. When I was getting ready to research this, I must have known this in dental school, but I didn't really realize it until I read it, reading through these articles, that all of the central incisors start to erupt very lingual to where the baby teeth tooth buds are. All the tooth buds are kind of lingual. So the tendency is if we're going to have those teeth coming in, they may come in lingual. So we've got that situation here, also here. And then this one's kind of scary because all you see is one tooth. The other ones are all hit. These can all be treated in different ways. So we've got a single tooth right here, and he actually has some good spacing in the back. We can actually use just a little finger spring, so if he's compliant, a little removable retainer with a finger spring, and just pushes that tooth forward. We ended up doing that with this patient too. We put 2 little finger springs forward so that we could push those teeth in front of the bottom ones. And once we did that, he had a huge teeth bite. So we ended up having to put some braces on him. You can see here, on this guy right here, you can see how the gum tissue is receded just from being pushed from those upper incisors. So it's really important when you see these anterior crossbites to get them seen, because you can have a lot of tissue damage. We've gone over some of these posterior crossbites a little bit too. We have a posterior crossbite like this with a midline shift. If this is not treated early and the patient continues to grow, you can have asymmetric growth of the jaw. Okay? And you get them in there and you go, oh my gosh, we can move your teeth, but we can't move your jaw anymore because it's already grown. And then we have, situation like this where it looks like it's unilateral, so we just have the crossbite on one side. It very often can be bilateral, and they're just shifting off to the side. And then, of course, we have a true bilateral on the bottom. So one of the other things that you'll see a lot of times, orthodontists will put braces on when we see crowding. Okay? Not all crowding braces. There are some other things that we can do. But you'll see it, a lot of orthodontists will put braces, especially on the lower front teeth for crowding. Usually it's from loss of primary teeth. There might have had some decay. There's some tooth size problems or missing teeth and eruption problems. So we're going to start off with kind of our easier one here. So and I don't usually see these. My pediatric dentist take care of this for me, which is great. We have a premature loss of a baby tooth, so we have these different space maintainers. So everything else looks pretty good here, space-wise, but we're missing back teeth. And if we leave those teeth on their own, the back teeth will drift into those extraction spaces. And then we're in big trouble because we're trying to find space, okay? So very simple, easy space maintainers. There's other times where we see this irregularity of the lower incisors. Oh, my son's teeth aren't perfectly straight. They need to go to the orthodontist. They got tons of space. Remember, we've got these huge primary second molars, big primary first molars, and then the canines. So we have what's called leeway space. Each side is about 2.5 millimeters of extra space back here for the permanent teeth that are going to come in. So that's great. If we have a little bit of crowding down here, we don't have to worry about anything. Right? We can just say, don't worry, we'll watch it. If it's a little bit more crowded, this is kind of scary looking. We can either extract these canine teeth and place a lingual arch in there. We might even disc them. So we'll do a little IPR on the canines, and we just leave them. Okay? Because we don't need to make any space. We don't need to put braces on. We can do it very simply with a lingual arch to hold the space, maybe some discing of the primary teeth. Does anybody have any questions about this? Now we've got a situation where a little bit of crowding. We've got tons of space back here. Oh, we got a tooth coming in. What do we do now? Do we start braces? Oh my gosh, we should totally start braces. Nope. But we may want to put a lingual arch in here and take this tooth out. Or if we have enough room, we might just disc it, have the pediatric dentist disc through it, or so that this tooth can come in. Because again, we've got all the room that we need, but if we don't take that tooth out or address this situation, what's going to happen is either the permanent tooth won't fully erupt, or it'll kind of come out to the side, or we'll lose that baby tooth, and nothing will go in there, and then all of a sudden, the patient comes in and they've lost a bunch of space on the bottom. So this is a situation where we had a patient who had tooth extracted prematurely, baby tooth extracted prematurely, and nothing got done. We just kind of said, it's a baby tooth, the new one will come in right afterwards, right? Well, it didn't. So this tooth is actually rotated in and moved forward. So we need to get a full premolar in this space here. We can use an appliance that looks like this, is called a pendulum appliance. And like I said, there's 1,000,001 appliances. Ask, you should all be sending your patients to me, but if you don't, start. No, you might see different appliances from different offices. But this is kind of a cool appliance because as this tooth rotates in, we can use this pendulum appliance to rotate it back out and distalize it at the same time. These are kind of cool too because you can put expansion screws in here if we need to get some expansion. So this is a really nice way of correcting the situation. When we take a look here, we've got it on both sides. This patient actually had both of the molars had come forward. And so we used what's called a distal jet appliance. And what this does is it bodily moves those teeth back, okay? Because where we're putting the force on is closer to center of resistance and rotation. Anyway, you'll get more bodily movement of those teeth going back together. And it's just usually have these little screw holes, and we just adjust them. And these get really great results, and we get tons of space from them. So we really like those. And then, of course, there's the other option if they have had these teeth that have tipped forward, both molars at the same time. We can use the tried and true headgear, which nobody wants their child to wear. So it's available if we also want to do some other things while we're in there too. Now, we can also do the same thing on the bottom. We can find some space using a distalizer on the bottom. One of the most common distalizers, I think, that gets a really nice result is these lip bumpers. When we use a lip bumper, basically what it does is it pushes the lower lip out of the way, it holds it away from the teeth. You get a couple of side effects. As the lip puts pressure on this lip bumper, it takes these molars and shoots them back a little bit. Okay, so you might get a millimeter or so of distalization. The other thing you'll see is spontaneous correction of this lower crowding, because there's no lip pressure on those teeth. They kind of unravel. But as soon as you take it off, they'll start to crowd again. Now, midline discrepancies. These are the ones I love when you guys send me patients like this, because this is a no-brainer. We have a patient where the midline of the top teeth does not match the midline of the bottom teeth. It's because when these 3 incisors came in, they took out the 4 baby incisors. So there's no room for this 4th incisor to come in. It typically comes in lingual. So this is really simple to do. She would need to have, of course, braces on the top and the bottom for 12 months. But we'll move that midline over so she has enough room for the canine tooth or the lateral incisor to come in. And then she's got so the foundation is laid for really nice alignment, so when the rest of the baby teeth come out, the permanent ones can just pop into place. So these are great ones too. The ones that are a little bit more challenging when we have crowding that's greater than 10 millimeters. And this is when we start talking about serial extraction, or now they're calling it guided eruption. And basically what it means is we're going to be monitoring the eruption of the baby teeth and the permanent teeth and taking out the permanent teeth over time. Okay, so we might wiggle out some baby teeth, watch the new ones come in, wiggle out some more, watch the new ones come in. When the first premolars start to poke through, we want to go and get them extracted. Again, it's just monitor, monitor, monitor until they have all their permanent teeth, and then we're talking about orthodontics just once. Okay. For severe crowding, when we have more than 10 millimeters, most important thing that I look at is that they need to have a good skeletal condition, and they need to have, meaning they should be class 1 versus class 2 or class 3. And they also need to have class 1 molars. If we don't have that, serial extraction can get really, really ugly. It can be really bad. Something else that we see a lot is diastemas. Now, we talked about the ugly duckling stage where we're going to have some spacing on those front teeth. Well, there's some spacing, and then there's some spacing. So why would we have that spacing? Well, we might have it because of a freedom attachment. It might be too low or too thick. We might have it because we're missing some teeth. We might be missing lateral incisors, and so these centrals are just kind of off to the side. There might be a 2-size discrepancy, so that even those centrals might be a little bit too big. And we could have a tongue thrust that's tipping them forward, creating the space between the front teeth. When I see a patient with a diastema, my number 1 thought is it something that's going to, are they going to grow out of it through the ugly duckling syndrome? Or is it something that we need to do to allow the lateral incisors to pop into place, or to take care of a behavioral issue, a tongue thrust or a speech issue? Studies have showed that the stability of an end result is improved if a large diastema is closed while the permanent teeth are still erupting. So we always talk about, well, once we close it, it's going to rebound back open. If we treat these when they're very young, we have a much higher stability rate. So we also have situations where we have abnormal eruption, right? So this little girl came in. This was her before pictures. And I was like, what is she doing here? That's ridiculous. She looks so cute. She's got these perfect straight teeth, class 1. There's the x-ray of her canines. These are her lateral incisors that have about 50% of root locks. And the central incisor has about 25–30% of root locks. She's got big, long roots on the canines. So this was a patient that was sent too late. Okay. When I take a look at this picture here, we can see that we've had some ankylosis of these teeth on the bottom, where failure to erupt of those primary teeth where they haven't exfoliated, and now the molars have tipped forward, And we've got all these teeth that are way up in the bone, and they're not developing the way they're supposed to. So you can send that to someone else. Just kidding. I love those. I love those. We actually just had a girl the other day come in, and she had a tooth that was impacted. I'm getting off course here. She had this impacted central incisor. Her midline was off to the side. She was a teenager, and her dad, midline's totally off. Teeth are not matching up. And you can see something's not right, but all the teeth are next to each other. And we take this x-ray and we see this tooth that's sticking like this. And I'm like, oh my gosh. So we're trying to tell the dad it's really important. It's her front tooth. I mean, kidding me? So we opened up the space, and now we finally got the tooth in. I'm so excited. Every time she comes in, I'm like, I love these. They're great. And they're always really good for teaching, right? I mean, it's fun to have everybody sit down and learn how the forces are. And then, of course, in this one, we have missing lateral incisors. Okay? So you want to make sure that if you don't have a pan machine in your office, you can send it to your orthodontist. They'll take the pan for free and send it to you. Yep. Congenitally missing permanent. I will. For you. For all of you, I will. So here we have some congenitally missing teeth. So we've got some mandibular premolars that are missing. And what's interesting is you can kind of see we have two different situations here. So on this side, all the teeth are at the same level. And on the other side, this tooth is kind of sunken down. And it's kind of hard to see in this picture here, but it's got the stainless steel crown on it. It's kind of sunken down about 2.5 millimeters below the occlusal plane, so where she wants to bite. The tooth above it is growing down into that space. It's what we call ankylosed, okay, or fused to the bone. Oftentimes we want to hold on to those primary molars for as long as we possibly can. It's going to maintain the ridge or the bone for a replacement and implant maybe down the road. But if we ever see a tooth that gets ankylosed and it starts sinking, like you might be looking at a patient, you're like, why does that tooth look like it's sinking? It's not that the tooth itself is sinking, it's that the rest of the face is developing on these growing kids. So everything else is growing up bigger, their face is changing, but these teeth are fused to the bone so they look like they're sinking. Now, when we have a situation like this, we're almost stuck with having to take the permanent tooth, or take the baby tooth out, and then using a space maintainer to hold this space. I talked to the pediatric dentist yesterday, and they're going to try to leave a little bit of root tip in here so that we can maintain some of that bone. There's not a whole lot of root tip there. And then, of course, on the other side, we have this tooth over here, but that premolar still can't come in, so we're going to get that one disced. And this patient, we hope that we don't have to do any kind of early treatment until she's older, until she's got more of her permanent teeth in. Then we can just do it once. And again, another picture of ankylosed teeth, keeping everything down. The other thing that it can do is really cause those molars to tip forward, and then we have space loss. And then we're looking at trying to find space. It's much easier to find space in the maxillary versus a mandibular jaw. So we want to maintain as much space as we can in the lower. So early treatment rationale, how did we get there? Sorry. Oh! Don't look. Oh! There we go, don't look. Look away. Okay. Lastly is craniofacial anomalies. So in this little patient, she's got a cleft lip and palate. They often have these really small maxillas. They're often missing teeth. So I saw her initially. She goes back and forth to UCSF, and we're just starting her treatment to do her ortho. We just waited until she had as many permanent teeth as she could. I think one of the big take-homes from this is phase 1 treatment. You call it a racket. To me, it's all about staging the treatment for that patient at just the right time. Some patients are going to require something when they're early, growth modification, all the other things that we've talked about, we have to do it when they're younger because it's going to dramatically change the way that they grow and develop. Some things we can monitor. We can do little bits here, little bits there, and we can just monitor it until it's just the right time. And so I think for early treatment, that's a really good take home. So benefit of early treatment, patients tend to be a little bit more cooperative and follow instructions. They have a little bit increased stability. We talked about the fact that those maxillary diastemas, when we close them earlier, they're a lot more stable. The other thing too is that when we treat these patients when they're younger, their gum tissue isn't, their teeth are coming through the proper gum tissue. They're coming through attached tissue. They're not coming in outside of the arch. So we have much better gingival situation. We can also modify habits while they're younger. We can reduce extractions by regaining space. We can reduce the risk of trauma by moving those protruded teeth backwards. We can reduce periodontal trauma from anterior crossbites. And then, of course, growth modification. We can reduce surgery in the future, which is really important. So I just wanted to show a couple of pictures of a patient. So this is one of my early treatment patients. She came in, she had a little bit of a deep bite, but she also had a midline that was swung over to the side because she was missing that primary canine. So we managed to create the space for the permanent dentition. And then she came back to me for her phase 2. When she was much older, she had crowding down here because she didn't wear her retainer. And we ended up doing it with Invisalign. She was done, I don't know, 9 months maybe. So it's really nice. It makes that second phase a lot easier, and it can be something, it can be Invisalign, whereas before we would be talking about braces. This patient, same kind of thing. I showed her picture before. She's missing this canine over here. We put an expander in, and FFA is full fixed appliances. So she had braces on her 4 front teeth on the top and the bottom, and bands on the molars. One of the other things I've been doing a little differently, some of you might have noticed it, is I've been adding brackets to the primary molars. So a single bracket, it just reduces the flexibility of the wires. What I find with these kids is there's these long wire spans between the lateral incisor and the molar band. It can be somewhat flexible. And the kids play with it, fidget, and ping! And it's, Saturday night. Hey! Oh, this is the one I wanted to talk to you about. So this was the patient with the open bite in the front. We placed this expander. It's a totally different type of expander than you've probably seen mostly in your office. They have the bands on the back. This one has acrylic across the occlusal surface. So what this was doing was correcting her shift while we were doing the expansion. As she was biting together, she was kind of intruding her molars too. So this was her when we took her expander off. So from that to that. And all we did was expand. I mean, awesome. So this was her at the beginning. This is her after we did phase 2, or we did braces on her. And you can see this was a true difference skeletally that we were able to do just with that expander. I mean, I wish it was something magical. Retention and maintenance phase. So we can use, if we are just doing an expander, we got a patient, all they have is crossbite. We don't need to put braces on to pretty up the teeth. That's a waste of time and money. What we need to do is correct that crossbite. We put the expander in, expand. 6 months later, you can either use the expander for your retainer, or we'll take them out and we'll put a transpalatal bar, and that's it. It's fixed retention. They don't have to they'll come back and see me, and I look at it, see that it's nice and strong. We don't have to worry about them losing or breaking their retainer. For patients that have braces, I'll do a conventional Hawley type of retainer, which has wire and acrylic. It's a phase 1 retainer. And basically what it does is it holds the molar position where it's at, and it holds the lateral to lateral position. I can adjust around the new teeth that are coming in. I can add a bite plane if I I want help with a deep bite correction. The biggest thing is it doesn't encapsulate the teeth, so as those canine teeth start dropping down and the laterals are tipped out, they can actually start to straighten up. That's really nice. The retainer still fits nicely. My protocol is to maintain the braces for about 3 months post the correction as their fixed retainer, and then debond and go straight into the phase 1 poly at nighttime only. You'll also notice on some of my cases, I will leave the laterals tipped out, so with the roots tipped distally, because those are with the crowns tipped distally and the roots mesial, because I don't want to run the root into my canine tooth that's developing. So don't be surprised when you look at it and you're like, she's thinking she took these off and those teeth are still a little tipped. They're tipped for a reason. I don't want to blow off any roots by moving them. So if they have high canines, I leave those lateral roots where they are. So big disadvantages. You know, we're running this racket. Time. Most patients that do a phase 1 and a phase 2, they are going to be in treatment more than one set of braces. It's because we're staging it at the right time. We don't stage it, then we've got different treatment options. And usually those different treatment options are not the ones we want. They're extractions, they're surgery, so we want to stay away from that. Financials. So typically, the increased cost between doing a single phase and doing 2 phases in our office is about $600, maybe $700. So it's really a good deal. They get 12 to 15 months, a retainer, final treatment, retainer, and it's only cost them about $600 more. And they've done it at the right time and they've reduced their risk. Oral hygiene for my little ones is tough, right? They're tiny, little mouths, really juicy, they're fidgety. They can be really tough to motivate to keep their teeth clean. Some of them are great, some of them not so great. All of our patients have the oval seal on, so at least their teeth are protected, so that we don't have to really, they're sealed essentially as we are continued through treatment. But we do, it requires parental involvement, so it takes a village when we do these early treatments. The other thing is emergencies. They tend to have more emergencies. I would say I see more of my phase 1 patients for emergencies than I do my other patients. And the type of emergencies are pokies, because they're always in their mouth playing. And yeah, it's higher risk of working on the weekend. So, and then patient burnout. They get tired of it. They're like, all right, you had braces. Oh, I have to do it again. So those are some things that we want to really look at too. So does anybody have any questions about some of the things that I presented today, or even some things that you've seen in your office and you're like, I don't understand why they did that or how they did that?
I have a question. Usually you're doing phase 2s that often it's you're often extracting bicuspids or is that how?
So my goal, if I'm going to do if I've already done a phase 1.
No, I'm saying you were looking at. I'd say if someone says, well, why don't I just do 1 phase? I don't have to pay the extra $600. But if you do 1 phase, you're treating them probably later as teenagers, and now you have some extractions, which probably cost more than $600.
I won't be taking them out though. I get to make some cash.
But I won't either.
No, because I do. I get a lot of resistance about this phase treatment, and really, I work more weekends. We have to deal with a lot of hygiene issues and emergencies and pokies and things. So it's, I'm not making any money on a phase 1, phase 2. It's a draw between that and just a comprehensive treatment, because there's so much more that goes into this 2-phase treatment. But at the end of the day, I've reduced the chance for them to have extraction. I've increased I've reduced their periodontal issues and their trauma. I mean, for me, it's more about, I don't care about the money as much as I care about making sure that we get it at the right time, and they get in and out, and they go and enjoy themselves, and then go tell all their friends, I'm already done. I only need to have Invisalign for a few months for my phase 2. That's what I like to hear. Or I only have to have braces for 9 months in phase 2. Love starts to develop, I've been seeing a lot more impacted second molars. And so if the second molars look like they're going to come right into place, then I can start them before they've erupted. But if it looks like we're going to have issues with the eruption of the second molars, I'm going to want to have them spend a little bit more time over at the oral surgeon getting some things done and prepping them, and then getting the braces on. Any other questions? Yes?
What are your thoughts on TADs?
For early treatment? Oh.
No, not really, man.
I was like, I wouldn't do it. TADs, I think they're great. Very specific. They're very great. They're very good. I take it back. I have used them in early treatment. And I've used them to maintain a lateral incisor. So what I've done is I've used a TAD in the alveolar ridge and built up a tooth so that the patient still has width of that alveolar bone so that they can have a full implant when they're older. And that way they don't break the pontic on that lateral incisor. So, but overall, TADs, they're great. I mean, there was a big push for them a few years back. Everybody had to have TADs.
What is a TAD?
Oh, sorry. A TAD is a temporary anchorage device. So, let's see. Let me get a picture. So, all right. So a TAD is this little tiny screw. It's like the thickness of a pencil, like from a mechanical pencil, really skinny. And you can put them in certain places to upright a molar or to help close space, like if you need extra help closing space. You can use them for cant correction. So I have this teeth roll like this. You put one up here and just grab onto it, and it moves the tooth. I have the whole kit. I did it all the time. I was like, oh, this is great. It was challenging. It was challenging to get the physics right. And so I use it for specific cases now, and not as much as I used to when they first came out. Yeah. Should I have a lunch and learn on that? Is that what I'm hearing from you?
Just curious, that's
You can
all.
put that on your. So, yes. Anything else? Okay, great. Please fill out your questionnaire. And if there is anything like this might have stimulated some conversation, like, ooh, that's something I don't know about, and I would like to know about that. I wonder if she's put on a class about cant correction, TAD. Yes.
How would you like us, as a team, to talk to our patients about phased treatment?
Okay.
Since you get them coming in your office saying,
Yes.
you're a scam.
So here's the thing. When you have a patient and they're 7, you're like, you know what? There are some things that I see that I really want little Susie to go see an orthodontist. And mom's going to be like, what? I say, I know, she's 7. When you and I grew up, everybody got the braces at 12. But nowadays, with the new technology and the way things are going, we can actually stage her treatment so she has a much more successful result at the end. And if we do it at just the right time, which is what the orthodontist will determine for you, do it just at the right time, she's going to have a much better result long term than waiting till she's older, and she might need to have a longer treatment, or she might need to have extractions. So let's just get her checked out. Does that sound okay?
Yeah, because for me, sometimes just getting them into your door is saying, just go in and talk about the simplest thing, do exactly what you want. And then I expect that you can pull up the rest.
Well, even just yesterday, I wish Tish was here, because yesterday we had a sibling come in that I had seen a ways back, and the mom said to me, oh, Lily was told that she could either wait for braces, like we could wait 9 months, or we could start the phase 1 now. And she's like, it's a divorce situation, so it was this whole big drama. And, I said, we can do either or. We can watch her grow. She's going to need something. Or we can do it now and get it over and done with. And in 9 months, you're looking at, being close to the end of this. And, but it is this, I like to give them the option. If we can observe, I'll put them on observation. But if it's borderline, I really want them to do it. And so when you get something back from us, because once we do an exam, you'll get something back that says, I recommended treatment, and and they come in, they don't have treatment, it's a good time to bring up, hey, you saw Dr. Linsky, she recommended treatment. Was there something you had concerns about? You know, and it's, you know, we follow up with them, but it's also really, you know, it is important to have everybody follow up. When you send me a patient and I see